Welcome back, everyone. This is the time of the meeting that we introduced the Hatter Award Lecture, and it really is a great privilege and honor for me to present Milton Packer to you today. I don't have to present, everybody knows who he is, but this is what's written on the Hatter Award document here. It says that the Hatter Award for 2019 is given to Professor Milton Packer, MD, whose pioneering research has led the way to our modern-day treatments for heart failure. Dr. Packer is an internationally recognized clinical investigator who has made numerous seminal contributions in the area, both in our understanding of its mechanisms and in defining its management. His internationally acclaimed research work is widely published and attests to the impact that he's made on the lives of those at risk of heart failure. So it really is a great honor and a privilege to ask Milton to come up, and I've learned something else about Milton today when we were chatting earlier, and that is not often you meet such an enthusiast. So thank you very much, Milton.
Thank you so much. I am deeply honored. I have had a wonderful time here. It is such a joy to be here with you, listening, learning. And so what I wanted to do was I wanted to tell you a story. It's sort of a long story, and they didn't give me forever. So I thought, well, how can I start this story? Because first, I didn't choose the title. But you know, when you're given a title, but you want to talk about something else, you do. And you sort of make the title fit what you wanted to talk about. So I'm going to do that. And what I want to do is begin with an observation that is really interesting. I have spent the last 40 years studying one disease, which is heart failure. It's an unbelievably interesting disease. If you want to understand the cardiovascular system, then observe the cardiovascular system when it is in chaos. If you want to understand how a society or organization really works, watch that organization operate under periods of stress. I didn't mention anything about Brexit. I didn't. And if you want to understand the heart and the circulation, watch it fall apart in slow motion. That is what makes heart failure so fascinating. One sees the circulation unravel over a period of weeks, months, years. And by watching it fall apart, one can understand the rules that governed its normal status. One can watch all of those principles disintegrate. But fortunately, they disintegrate slowly, so we can measure them, and we can understand them, and we can pretend that we understand them well enough to intervene. The truth is, though, that studying heart failure is a humiliating experience. Really humiliating. Do you realize that in the last 40 years, we have developed a whole host of medications for heart failure, which have had dramatic effects on quality of life, on morbidity, on mortality? You could say we have done a fantastic job. Do you realize not one of those drugs was actually developed for heart failure? We didn't develop diuretics for heart failure. We developed ACE inhibitors for hypertension, beta blockers for arrhythmias. I don't really know why we developed spironolactone, but that's a whole different story. Sacubitril valsartan was an antihypertensive. Almost none of the drugs, actually none, were developed for heart failure. We, in the field of heart failure, we stole those drugs from other fields. And we did so without any apologies whatsoever. So I am going to tell you today about another theft. This one is a theft that you are going to see in front of your very own eyes. I am going to talk about the theft that heart failure specialists, heart failure investigators, heart failure physicians, we are now stealing drugs from diabetes in order to treat heart failure. Here's the great news. We actually think we deserve them. We think they belong to us. And that is what my talk is about. Okay, so think diabetes and heart failure are two different diseases? Well, we've already heard a wonderful talk by Dr. Feinberg that says that, well, gee, you know, the genes in the heart and the genes in the pancreas they're the same genes. If one fails, the other fails, what's the difference? Well, maybe there isn't much. There's a relationship between hyperglycemia and the development of heart failure. So diabetes begets heart failure. Heart failure begets diabetes. If you have heart failure, you develop insulin resistance, develop worsening diabetes. If you put in a left ventricular assist device and reduce the heart failure, you reduce the diabetes. Both diabetes and heart failure are characterized by the activation of neurohormonal systems, sympathetic nervous system, renin-angiotensin system, aldosterone, neprilysin. They're all activated in diabetes and in heart failure. And interestingly, they drive the progression of heart failure. And here's the secret. They drive the progression of diabetes. They're responsible for the microvascular disease of diabetes. If you have heard rumors that the microvascular disease is related to blood glucose, it's just one of those things that you read on the internet. So it gets even more interesting. We think that distending pressures in chambers cause injury. Well, if we have increased distending pressures in the left ventricle, that causes remodeling, that causes injury. If you have increased distending pressures in the glomerulus, that causes injury. One is called diabetes, diabetic kidney disease. The other one is called heart failure. And if you want to make it interesting a little bit more, I'll give you my own the interesting observation, which is the drugs we use for both diseases, well, they're sort of the same. We use ACE inhibitors for the left ventricle and for diabetic kidney disease. Angiotensin receptor blockers, neprilysin inhibitors have favorable effects on both. Maybe mineralocorticoid receptor antagonists have effect on both, certainly on heart failure, maybe on diabetic nephropathy. There are ongoing trials to find that out. And it gets even more interesting because I think that one of the most important mediators of organ injury is the activation of the sodium-hydrogen exchange mechanism, specifically isoform 1 in the heart, isoform 3 in the kidneys. And guess what? In heart failure, both are activated. The activation of NHE3 causes sodium retention. The activation of NHE1 has a toxic effect on myocytes. And two together can lead to heart failure. And the same thing occurs in diabetes. Activation of sodium hydrogen exchanger 1 has been implicated in retinopathy, in neuropathy, in the cardiomyopathy of diabetes. And of course, the activation of NHE3, especially in the proximal tubule, has been implicated in the hyperreabsorption of sodium in the proximal tubule, which has been implicated in the pathogenesis of glomerular hypertension, which drives diabetic nephropathy. These are pretty similar diseases. So, and we realize that although everyone here is told that the reason to treat diabetes is because diabetics are at risk of myocardial infarction and stroke, and they're at risk of injury to the eyes and nerves and kidneys. The truth is that what they're really at risk of is heart failure. That's the most important complication of diabetes. It's the earliest complication of diabetes. It's the most preventable complication of diabetes. It's the most treatable, and it's the one no one talks about. So, if I were interested in theft, if I were a heart failure investigator and I wanted to steal a drug for heart failure, where would I look? I would look at drugs which are currently referred to as anti-diabetic drugs. It's just a name. The fact that they lower blood sugar is simply a historical accident. But if I wanted to steal a drug, I would steal an anti-diabetic drug for all the reasons that I've explained. And what's great is I have lots of anti-diabetic drugs I can steal. Oh, by the way, some of them I want to leave behind. Others I would be really interested in borrowing for a long period of time. So let's think about how this could work. Just suppose that I believe that activation of sodium-hydrogen exchange was important in both diseases. Just suppose I believe that the activation of NHE1 in the heart caused injury, NHE3 caused sodium retention glomerular hyperfiltration, then I would be interested in what drugs actually did to these mechanisms, and I would be interested in why these mechanisms were toxic. So let's take a look first at NHE1 in the heart. So it's known that NHE1 in the heart is markedly expressed in two diseases: diabetes, heart failure. And if you activate NHE1, you increase intracellular sodium, and because of the sodium-calcium exchanger, you increase intracellular calcium, and it is believed that the activation of NHE1 causes calcium overload and compromises the viability of cardiomyocytes. That is a toxic effect that's been seen in a variety of different experimental models. It's been seen in vitro, in vivo. And what's interesting is that about 10 years ago, people were excited about blocking this exchange mechanism with a drug called Caripiride. It's a drug that was developed by a small pharmaceutical company who thought that the drug might be useful in preventing myocardial injury in patients undergoing coronary artery bypass surgery. So they did 3 big randomized trials. Most of these trials you either did not ever hear about, or if you heard about, you have forgotten. Let me summarize the results of these trials. They all looked like this. If you gave Caripiride to patients who were undergoing cardiopulmonary bypass, had myocardial ischemia, these were patients who had long-standing coronary artery disease, you had a striking reduction in the risk of perioperative myocardial infarction. This was seen not in trials of 50 or 500 patients. These were seen in trials of 6,000 patients, and it was seen in 3 different trials. Caripiride was developed as a specific inhibitor of sodium hydrogen exchange isoform 1. So it became really interesting. But the drug had some limitations. Because of its limitations, the excitement about inhibiting NHE1 subsided, and it remained quiescent for a long time. A similar phenomenon occurred with sodium hydrogen exchange in the kidney. Sodium hydrogen exchanger 3 in the kidney is expressed almost entirely in the early proximal tubule. In fact, NHE3 is almost only expressed here and not expressed in almost any other organ in the body. What does it do? Well, it's actually responsible for most of the proximal tubular reabsorption of sodium, which, by the way, largely takes place in the proximal tubule, not in the loop of Henle, not in the distal tubule. And if you have enhanced sodium reabsorption, then you have decreased sodium delivery to the macula densa through tubular glomerular feedback. That causes the afferent arteriole to dilate and causes glomerular hypertension. It is the belief by many that it is the activation of this isoform causing hyperabsorption of sodium in the proximal tubule that is the cause of glomerular hypertension in diabetes. So it's interesting. If that's true, then maybe one can block this enzyme, this isoform, the exchanger in the proximal tubule. And what's interesting is that we sort of have a drug that does that, but we don't call it that. Mineralocorticoid receptor antagonists actually block this isoform. Some people believe that's the major mechanism by which they may work in slowing the progression of diabetic nephropathy. But we don't know. We have clinical trials in progress. We'll be smarter in a couple years. Okay. I've given you an example of a couple drugs that inhibit sodium hydrogen exchange, 1 in the heart, 3 in the kidney. But can we actually activate these mechanisms? And if we activated these mechanisms, would we make people worse? Well, the answer is, I think so. One great way of activating these mechanisms, by the way, is a drug, interesting drug, it's called insulin. Very popular drug for the treatment of diabetes. Happens to activate sodium hydrogen exchanger 1 in the heart and 2 and 3 in the kidney. Insulin, if you give it in a variety of experimental models and in the laboratory, has toxic effects on the heart. It definitely has anti-natriuretic effect. It causes sodium retention. And what's amazing is that there's one drug, one class of drugs, which are TZDs. And they greatly potentiate the action of insulin on sodium hydrogen exchanger 3, which is why these drugs all cause marked amounts of sodium retention, particularly in patients who are getting insulin and have been associated with a 3 to 4-fold increase in the risk of heart failure. So we can make sodium hydrogen exchanger activity in both organs go down. We can make them go up. What else can we do? Well, there's one question. Can we actually develop a drug? Can we resurrect the idea of cariparide and block these sodium hydrogen exchange mechanisms much more directly? Well, we can if we realize that sodium hydrogen exchange isoforms are closely intertwined structurally and functionally with the sodium glucose cotransporter 2 mechanism. They live right next to each other. They embrace each other. They have a civil marriage. And that happens both in the kidneys and in the heart. In the proximal tubule, these two enzymes are intertwined. This is where most of the sodium and glucose reabsorption takes place. And what is so interesting is that they're intertwined in the heart as well. It's so interesting because if you stain for SGLT2 in the heart, you won't find any. But there's a docking site for SGLT2 on sodium hydrogen exchanger 1. And that docking site regulates the activity of NHE1. So when you inhibit SGLT2, you also inhibit sodium hydrogen exchanger 1. So SGLT2 inhibitors are really sodium hydrogen exchange isoform inhibitors. NHE1 in the heart, NHE2 in the kidney. If you inhibit NHE3 in the kidney, you get a natriuresis, hemoconcentration, decreased glomerular hyperfiltration. you get all of these following the administration of SGLT2 inhibitors, which is why in large-scale cardiovascular outcome trials, there's a decrease in the progression of diabetic renal disease in almost every single cardiovascular outcome trial that has been done with SGLT2 inhibitors, be it empagliflozin, dapagliflozin, canagliflozin. But one that I'm really interested in is the inhibition of NHE1 in the heart. There's been some really fantastic work from the group of Bart Shearer and colleagues showing that SGLT2 inhibitors act as sodium-hydrogen exchange 1 inhibitors in cardiomyocytes, particularly in diabetic cardiomyocytes. This is from their work. And you can see that a drug like empagliflozin markedly decreases intracellular sodium. It markedly decreases cardiomyocyte death and decreases myocardial infarct size in an experimental model. It's a diabetic mouse. And in clinical trials, one striking signal across all the cardiovascular outcome trials has been a decrease in hospitalizations for heart failure in each of the trials, ranging somewhere between 25 and 35%. This is actually the major signal of efficacy of these drugs. They really don't do very much to myocardial infarction or stroke, actually almost nothing. But they do slow the progression of diabetic nephropathy, and they do reduce the development of heart failure and heart failure hospitalizations. And what kind of heart failure? Well, we have heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. These are just recently published data from the DECLARE TIMI 53 trial. Just came out in circulation about a week or two ago. And look at what they found based on the phenotype of heart failure at the time of enrollment in the trial. If patients didn't have heart failure at the beginning, there was no benefit on heart failure events. If they had heart failure with what they thought was preserved ejection fraction, not really much of anything. But if they had heart failure with a reduced ejection fraction at the time of their baseline evaluation, this is what they observed. These are diabetic patients. These are post hoc analyses based on pre-randomization assessments of ejection fraction, but they certainly would support something going on, something cardioprotective in patients with heart failure and a reduced ejection fraction with an SGLT2 inhibitor. Well, we're going to find out. We've given up on diabetes. We have stolen this drug from the endocrinologists. They really weren't making optimal use of it anyway. We decided we wanted to make these heart failure drugs. And since we were very experienced in theft, we decided to become quite serious in looking at these trials in heart failure populations. There's a large trial with dapagliflozin, a large trial with empagliflozin, both with heart failure and a reduced ejection fraction. You can see that we're not far away from seeing the results of these trials. These trials started about 5-6 years ago. Remember, in heart failure, we have very long incubation periods. We'll get the results of both of these trials probably in the next 18 months. There could also be an effect of these drugs in patients with heart failure and a preserved ejection fraction, but this is trickier. This is a disease which is really complicated. It is difficult to understand. There are many subphenotypes of this disease. There are people who have abnormalities of titin. There are individuals who have abnormal protein aggregates of amyloid. But I think the one area that I'm personally excited about is the fact that many patients with heart failure and the preserved ejection fraction have inflammation of epicardial adipose tissue that causes inflammation of the underlying myocardium that causes destruction of the microvasculature and cardiac fibrosis. Diabetic patients have markedly thickened and inflamed epicardial fat, regardless of body mass index. And what's really interesting is that this epicardial adipose tissue secretes pro-inflammatory cytokines. It also is the source of mesenchymal stem cells that can be pro-inflammatory, be transformed into fibroblasts. That all can lead to the decreased distensibility that's seen in heart failure with a preserved ejection fraction. If you give SGLT2 inhibitors to patients, 5 trials, 5 different SGLT2 inhibitors, all of them showing a shrinkage of epicardial fat, and in one study, experimental, a decrease in the inflammation of adipocytes in the epicardium following SGLT2 inhibitors. So we're interested in whether these drugs might actually work in heart failure with a preserved ejection fraction, and there are 2 trials. You can see the 2 trials. They're a little bit behind the other trials. This is a disease that's a little bit harder to recruit for. The event rates are a little bit lower. The follow-up periods are a little bit longer. So we won't be getting the results of these trials until about 2021, 2022. I have to emphasize, all the heart failure trials that you have seen, I've shown 4 of them in progress. They're including patients with and without diabetes. 50% don't have diabetes. All of them start with heart failure, but most importantly, in all of these trials, people are already getting best care possible for their underlying heart failure. So these drugs are being added to conventional therapy. Finally, I'll just mention quickly a few comments about incretin-based drugs. GLP-1 receptor agonists, there are complicated drugs. They really lower blood glucose, but what do they do to heart failure? Well, in heart failure with a reduced ejection fraction, we have concerns. There are 2 trials. They're small, both showing an increase in adverse cardiac effects with ularitide over a period of 6 months. But interesting, and what's interesting is these drugs are known to increase cyclic AMP. We don't think that's necessarily a good thing in heart failure. They do have a modest increase in heart rate. We don't think that's a good thing either. And so we're worried about the fact that they can actually exacerbate cardiac injury. But in large-scale clinical trials, there hasn't been an adverse signal for heart failure events. So the question is, why not? And I think it's because GLP-1 receptor agonists also shrink epicardial adipose tissue. They're anti-inflammatory for adipocytes derived from the epicardium. And therefore, although they might have an adverse effect in heart failure with a reduced ejection fraction, they could have a favorable effect in heart failure with a preserved ejection fraction, and maybe that's why the total effect we see in diabetes trials thus far has been neutral. We're seeing the net effect of a positive effect on heart failure with preserved ejection fraction, but potentially a negative deleterious effect in heart failure with a reduced ejection fraction. Finally, D3P4 inhibitors, physicians love these drugs. They lower blood glucose, and they do nothing else. Nothing else. They don't spare the heart. They don't spare the kidneys. They lower blood glucose. And they do have some interesting issues. Remember, SGLT2 inhibitors reduce heart failure events. Some DPP4 inhibitors increase heart failure events. You might say, well, that's just one trial with saxagliptin in one study. But similar signals have been seen with allogliptin, vildagliptin, maybe not all the gliptins, but many gliptins. And the worrisome thing about these drugs is that not only do they enhance GLP-1, but they enhance stromal cell-derived factor 1. And this is a chemokine that increases sympathetic activity, has pro-inflammatory effects on epicardial fat, would be expected to theoretically make heart failure with a reduced ejection fraction worse, heart failure with a preserved ejection fraction worse. These drugs are not neutral. If anything, from a heart failure point of view, we are worried about them. So, heart failure investigators, heart failure researchers, are always interested in stealing drugs from other fields. And the reason is pharmaceutical companies won't invest in us in our own right. The only way we're going to make progress in heart failure is to tell people that, gee, you know, the drug that you have for hypertension, the drug that you have for arrhythmias, the drugs that you have for diabetes, they are mislabeled. They're really not for hypertension. They're really not for diabetes. They're for heart failure. But by the way, since you've invested $1 billion to develop them, can we test them in heart failure? We have been playing this game for 40 years. By the way, really successfully. We are ready for our next theft. Our next theft is the invasion of the field of diabetes. It is a gold mine for heart failure therapies, both therapies that make it better and therapies that make it worse. The last thing that these drugs are anti-diabetic drugs. Thank you very much.